I'm going to talk briefly about some evidence gaps in obesity guidelines, and it would mainly focus on the comparing medication for obesity. About the obesity guidelines, there are many guidelines for managing obesity, but I picked 3 guidelines to review. And the first one is the American Heart Association, American College of Cardiology, and the Obesity Society guidelines in 2013. And the second is American Association of Clinical Endocrinologists and American College of Endocrinology guidelines in 2016. And lastly, the 2025 American Diabetes Association guideline. The AHA-ACC-TOS guidelines give us quite general guidance on obesity based on critical questions. However, this is somewhat outdated now. So therefore, there is limited guidance on FDA-approved new pharmacotherapies and procedures and devices. Fortunately, ACC and AHA provide some additional guidance on obesity and overweight in their other guidelines as well, such as the primary prevention of cardiovascular disease guidelines. But yeah, they have some limitation because they are quite outdated. The 2016 AAC and AC guidelines provide quite holistic approach on managing overweight and obesity based on critical questions on diagnosis and complications and treatment. They clearly provide evidence gaps in their recommendations on treatment. So I focused on evidence gaps from this guideline in the next slide. And 2025 ADA guidelines mainly focus on diabetes, but they have a separate section on obesity and weight management for the prevention and treatment of type 2 diabetes. The distinct point of this guidance is that they include and recommend very recent medications for obesity, like semaglutide of GLP-1RA and then tirzepatide of dual GIP and GLP-1RA. So what is evidence gaps in those? So most guidelines, especially AACE and ACE guidelines, highlight that there is very limited head-to-head study on efficacy, effectiveness, and safety of anti-obesity medications. Also, large and long-term followed literature are definitely required because most RCTs are conducted in relatively small sample with short-term periods. Further, there is lack of evidence on other related outcomes, for example, cardiovascular outcomes or psychiatric outcomes between drugs, and evidence on outcomes in underrepresented population, including older adults. The AAC-AC guideline depict their preferred medications by clinical characteristics or coexisting disease very clearly, and we can easily see and notice where we can fill in this gap through this table. So even though we can expect challenges in conducting network studies, including limited data on prescription of anti-obesity medication due to their limited insurance coverage or limited biomarkers like weight, BMI, or race circumstance and others. However, I think providing evidence on effectiveness and safety of anti-obesity medications is quite important because it can be used as a critical reference when Obesity Society decides to prioritize medication in this new era of anti-obesity medications.